and that's Jay Bhattacharya from Stanford University. Jay spoke to our last symposium, and a lot has happened since then, hasn't it? Including the Great Barrington Declaration is one of the biggies. We spoke to Sinatra at the start of the symposium a couple of hours ago, Jay. So we have covered that ground, or some of it anyway. So I will, and I'd like to ask you a bit about that at the end. But what would you like to talk about today?
I was hoping to I put together a presentation about my thoughts on this zero COVID policy.
Oh yeah,
because it's making the rounds, and I think well, you'll see you probably can guess my opinion about it. I think it's a dangerous idea, and I wanted to make the case that is in fact that it is a dangerous idea.
Okay, that's great. Well, let's fire away. We've got an hour, so we're up to an hour. So take as long as you need. There will be lots of questions, I'm sure. So leave some time for that too.
Wonderful. I mean, I think it should take about half an hour.
That's great. We're very pleased to have you with us. Thanks, Jay.
Let me see if I can share the screen and get this going. Okay. Yeah. So I wasn't subtle in my titling. I think it's So zero COVID sounds like a fantastic idea. We all want to live in a world where COVID.
Hey Jay, do you want to stick the presentation on to? At the moment, it's not on present or not on, so we can see the.
Sorry.
That's all right.
Let me see if I can get this right. Apologize. Let's see.
No, that's all right. It will work that way if it needs to.
How about this?
So if you go to presentation mode. Somewhere.
Is it on presentation mode now?
No.
Okay, let me try one more time. All right, put this on presentation mode, and then go. You'd think I would, as a professor, have done this enough times that this would not be a.
No, you're not the only person to whom it's happened today, so don't worry about that.
Here we go. Okay.
Yes.
Okay.
All right. Thank you.
Okay, yeah. So right. So I have not chosen a subtle title, but you know, like to talk about this, I think it does help to start by acknowledging the attraction of the idea. The attraction is simple. We all wish we lived in a world without COVID, and in some places, New Zealand, most prominently, you all live in a place where there just isn't a lot of COVID, and you can see videos passed around by people in the United States, I can tell you for certain, but elsewhere, of normal life going on in New Zealand, and this idea that we can all have this if we just work hard enough to get to this. That it's a very attractive idea. But the case I want to make is that this is a utopian nightmare, right? In fact, it's entirely unachievable, and the attempt to do so on a worldwide basis will cause catastrophic harm. Okay, so first, let me just talk about what is the endpoint of this epidemic. And really, there's only two possible endpoints of the epidemic. Either the world will end up in a spot where there is no COVID anywhere on the face of the earth, literally nowhere on the face of the earth, or we'll end up in a spot where, in the language of the models, it's called endemic equilibrium. We end up in a spot where COVID exists alongside the hundreds of other pathogens that humans face, and we learn to live with it. We learn to live with it. It won't be a disease that produces the kind of devastating harm that was produced last year, because there's too many people that have been infected with it, and I'll make that case later. So there's sort of population immunity in the very long run. Maybe even just a few years from now, what happens is kids get it when they're little, and they're potentially reinfected every few years. But the reinfections, when they get it when their kids are they get a very mild disease, but that produces a lasting immunity, and the reinfections just produce mild colds. It'll be like the other coronaviruses. That's the endemic equilibrium, where we learn to live with COVID, and in the meantime, we have to protect the vulnerable, the old, who we know to be the most at risk from the disease. So you have these two very, very different endpoints for the epidemic. And with with camps arguing for both, right? So the World Health Organization actually has inched away from this idea of zero COVID. You can see this from a couple of headlines I just pulled for this slide. saying that COVID-19 may never go away, that it's too tricky for zero COVID strategy in Europe. And I'll tell you, I think that it's like a very sensible thing that they're doing by walking away from it. At the same time, I've seen governments, the Canadian government, for instance, the Irish government, for instance, a few others arguing or trying to prepare their population for a zero COVID policy with sort of extensive lockdowns that will continue until such time as COVID is eliminated. Okay, so I wanted to take the opportunity to talk about what, from an epidemiologic point of view, what does it take to eradicate a disease? And this is not controversial. This predates COVID, and it's. I just put together a very short list. There's more that you would want to put on this list, but I think these are the relevant things I wanted to discuss today. First, you need a technology for quick detection of all infections, right? If you want zero COVID, you can't have cases or infections floating around outside of the purview of the public health authorities, because if you do, the disease you stomp it in one place and it pops up in another place without your knowing, and then you're just continually stomping it all without actually knowing exactly where it is. You need a technology for quick detection. I just want to say that the PCR technology we have now is actually not enough. What I mean by technology is not simply just a test, but also an infrastructure that can be used to test at a population level very, very frequently, such that we can find every case, every infection, whether or not it produces symptoms altogether. So that technology, I don't think exists anywhere on Earth. Okay, second, we need no non-human reservoirs of the infections. Why? This is, again, a classic sort of requirement for eradicating a disease. It's very, very simple. You can eradicate it in humans, but if there's non-human reservoirs, you can get reinfected into the population. I mean, very famously, of course, it's there's the theory that SARS-CoV-2 originated in bats. So in principle, this is already violated, but you know, we can consider that. Third, you need limited geographic spread. Why is that? Because in every single successful eradication campaign, and actually, frankly, I'm going to go cover both of them. In the history of the world, it's required the cooperation of local governments, and if you have to bring the cooperation of every single government in the world on board to this, it's going to be an insuperable challenge. Limited geographic spread is a very, very important feature of successful campaigns. And again, let me describe that a bit. And finally, you need a vaccine that disrupts disease spread. And I'll talk a little bit about the evidence around that. I think we may have one, but it's hard to say from the evidence we have to date. We don't know that for certain as yet for COVID-19. Okay, so let me start with an example that's less well known, but it's really important, of a infectious disease that actually has been eradicated. It's one of two that have involved extensive campaigns that have actually led to the eradication, and it's a disease called rinderpest. Rinderpest was a disease of cattle, of cattle. It was a virus. And you can see from the sort of old-timey picture the kind of devastation it would wreak. It would take big cattle herds and kill all of them. It's a disease that's spread by respiratory droplets, spread by cows. Cows and cattle in close proximity to one another would spread the disease to one another. And you can sort of get a sense of the devastation from this picture. It caused billions of dollars of damage. And it was just a complete disaster. It had sort of not quite worldwide scope. The New World sort of escaped it for the most part. It started in Scandinavia in the 1700s, at least was first detected in Scandinavia in the 1700s, spread through Europe in the 1800s, and then spread in the 1900s, sort of spread through Africa, through Asia. A lot of the spread, a lot of the European cases sort of started to go down in the 1800s with the development of a vaccine, which I'll talk about. But then it sort of took hold in Africa and Asia, mainly, but there was a massive effort to develop better vaccines, and which eventually led to the eradication of the disease, a huge success. And so let me just go through a brief timeline. In 1887, it was first introduced into Africa. Rinderpest introduced to Africa. It was Robert Koch, the famous Koch postulates, actually developed a serum that could inoculate cows against the rinderpest vaccine, the virus. There was a big advance in 1960 by virologists who developed a vaccine for it called the plow-right tissue culture vaccine, which was a big improvement over Koch's serum. And there was a mass vaccination program that was instituted by in 1962. It was supposed to last 15 years, and it was a huge success. Right, it led to the reduction of the geographic spread to only 2 locations in Africa. The campaign ended, and then the disease exploded all through Africa. There was a resurgence of rinderpest in sub-Saharan Africa in 1980. The problem was there was no vaccine that could reach remote areas. This vaccine that had been, this plow-right tissue culture vaccine, required sort of a cold chain, which was difficult to maintain in remote areas of sub-Saharan Africa. And so when it wasn't until 1990 the thermostable vaccine was developed. And this was the key tool, technological tool, but it wasn't enough. What was also needed was cooperation of local governments, and local meaning literally local governments, and local tribal elders and people who kept cows all through Africa, where the rinderpest was, in order for this thermostable vaccine to actually be applied. The earlier programs had involved mass vaccination programs all through India, for instance, of cows all through India. The problem was the mass vaccination programs weren't reaching areas, these remote areas, and the disease persisted. So you had these community-based vaccination delivery and targeted vaccination, rather than these mass vaccination programs, that finally led to the success of global eradication. I think the last case was found in 2001 or 2 or 3 or something, but by 2011 was the final official date when the disease was eradicated. So if you look at the sources that look back at this, what they conclude is that they actually say some things that are really quite relevant for COVID-19, right? In some sense, said rinderpest was a so-called dead-end disease for wild herds, as their low population density inhibited the spread of the disease. So herds that were really, really tightly packed together, lots of high density herds, that's where the disease spread. That's where those, like the picture that I started with, you saw. Together with the development of potent vaccine in 1960, the dead end in wild herds played an important role in achieving disease eradication in 2011. Right, so the vaccine was necessary. The existence of thinned out herds was necessary. The cooperation of local governments was necessary, and it took more than 100 years. 3 billion doses of rinderpest vaccinations were developed over 6 decades. It was, I guess, a massive global effort to rid the world of this disease that inflicted cows, this virus-infected cows. So this is from another sort of retrospective, looking back on what worked. It said, regarding the use of rinderpest vaccine as a tool to eradicate the virus, the 2 most important conclusions may be drawn. First, as shown during the vaccination campaign and during the first 30 years of vaccination in India, mass vaccinations of entire epidemiologically rated populations is an extremely blunt and expensive tool. While undoubtedly able to reduce the rate of virus transmission in affected areas, concentrating on repeatedly vaccinating extremely large numbers of animals, most of which were not at risk, distracted attention from the existence of residual foci and the persistence of the virus in contaminated trading environments. Okay, what can we learn from this? I'll come back to that, because I want to talk about a human disease that has been eradicated, just so we can understand again the common theme here is although this was a virus that afflicted cows, and it was an eradication campaign that afflicted cows, that helped cows and humans that tended them. We should also look to the one disease that actually has been eradicated in humans, and that with an intentional effort, and that is smallpox. So smallpox goes back at least 3,500 years. It's been found in the tombs of pharaohs. It was a disfiguring viral disease. You can sort of see some of the pictures from smallpox with the pustules. It was once you had it, it could just disfigure you permanently. The infection fatality rate was enormously high. Right? I think the case fatality rate is something like 30%. I mean, a really, really high death rate from smallpox throughout history. It was the most dreaded viral disease in history. It was eradicated by a decades-long effort in the 20th century, led in part by this man. This is Donald Henderson, probably the most and rightfully so, the most prominent and well-known epidemiologist of the 20th century. And I wanted to give you, I hope this works, I can give you in his words, why was smallpox a good candidate for eradication?
Well, smallpox was the most feared disease. At the time they decided to undertake eradication, and had been right through history. It had been the most feared disease. So there's a lot of interest in the part of a lot of countries in eradicating smallpox. The smallpox is a special situation because it is a virus. It can only spread from person to person to person. So in order to survive, it has to keep infecting people. And if at some point it fails to infect somebody, it stops. And there's no animal involved here. Smallpox does not infect animals. So if we could stop smallpox, this chain of infection, that would be the end of smallpox, because it would not recur as a result of infection from animals.
Okay, so what you have is a disease that's only spread from human to human. There was a fantastic vaccine that was developed, and yet the eradication effort still took decades. Well, why is that? Because it was similar to rinderpest. There was this mass vaccination campaign that actually made an enormous amount of progress in reducing the geographic spread of smallpox to a very few areas. But in those areas, once the risk of smallpox had come down, people stopped taking the vaccine. They were resistant to taking the vaccine. They just didn't. It wasn't like an easy thing. The more successful the effort was, the more difficult it became to end the effort. Okay, so let me show you what happened at the end. Was there was a team put together by Dr. Henderson and the World Health Organization that would find cases, that would have this massive worldwide surveillance system looking for even a single case. They would descend on the town that had the case. They would vaccinate the people, all the contacts around them, and there was an enormous effort to try to stamp out the remaining cases. It took decades, and it was a huge effort. Let me show you his. So this is sort of his victory lap, talking about how the last cases were stomped out. And this is just only a couple of minutes, I promise, worth your time.
The most severe form of the disease, called variola major, was prevalent throughout Asia, and it killed about 30% of the people. We managed to get rid of it in country after country, and it was finally in Bangladesh. We thought we had it in that area. And the last days in smallpox in Bangladesh were very dramatic indeed. We had celebrated on the 15th of August, 1975, the eradication of smallpox in India. And I flew with Director General and I were to fly to Bangladesh to encourage them to try to finish up. And we couldn't get on the plane. There'd been a coup. The president of the country had been shot. His family had been shot. Armies were moving to the border. It looked like we would have refugees. And we had no idea. We thought, my goodness, we've got it cornered in one country, in only one part of one country, and what's going to happen. Surprisingly, quiet. There was a period of quiet after this, and our teams went working very hard. And all of a sudden, we were finished. And suddenly there was this Well, we were looking at it, there were no cases. Went for 6, 8 weeks, no cases. And abruptly in came a telegram, there's one more case, way off on a distant island with a lot of people, but there was smallpox. And so you can imagine the resources that were poured into that. And they came by steamer and motorboat and paddle by canoe, however, to vaccinate and make sure it was the last case. And so that was the last case in Bola Island in Bangladesh. We waited then for weeks while we checked all through Bangladesh and other countries to be sure, but indeed that turned out to be the last case.
I mean, that was a huge success, an enormous success, and you can hear sort of how the last years of smallpox eradication went. It took years. It took a massive surveillance system. It took massive effort to isolate even single cases. It wasn't a disease by the end that was widespread. It was a disease that was geographically isolated, so you can get a sense of like where it was in 1945 when the World Health Organization, in this top right picture, how widespread it was, where it was endemic. The idea to eradicate it didn't start in 1945 when it was so widespread. The idea was to control it, to manage it through epidemic, through the vaccine. But over time, as the extent of smallpox shrunk down, it became possible. It became imaginable, and it was a huge successful campaign in order to do that. Now, if you're asking, was it worth it? The answer is yes. Let me just, and I'm going to do this just briefly because I think this is a bit of economic epidemiology that's worthwhile thinking about in the context of COVID. So I draw this from my textbook on health economics. I have a chapter on economic epidemiology. Let me just tell you one of the key ideas in economic epidemiology is that the extent to which people are willing to self-protect against a disease is very closely linked to the risk they face from the disease. You can see this in COVID. When cases are high and rising, people are willing to undertake all kinds of self-protective activities, even ones that don't necessarily result in much protection. So the compliance with masks, social distancing, lockdown orders, and so on are much higher when the perceived threat of disease is high. When the perceived threat of disease is low, those kinds of self-protective activities are not actually all that popular. So in New Zealand, I gather and I hope that there is not, in general, not a lockdown. In general, people are living their lives freely. They're not scared of COVID because there's zero COVID on the island. Right, so that's completely consistent with what you'd expect with if you follow this sort of idea of economic epidemiology. Less disease leads to less self-protection, but there's a cycle. Less self-protection can lead to more disease, and then more disease leads to more self-protection, and you get this sort of cyclical kind of equilibrium kind of phenomenon. Where essentially it's consistent with endemicity. It's very difficult to eradicate a disease because people's guard will naturally and should naturally go down when there is less disease. Second thing, how should we think about the disease and the protection? Well, in epidemiology, sometimes we like to think about the protection, the self-protection, as a good thing, and the disease as a bad thing. I'll tell you that's only half true. The disease absolutely is a bad thing, but the self-protection is also a bad thing. It's a cost that we bear in order to avoid the disease. It would be better not to have to bear that cost at all, but it's like a tax, right? Taxes, what you buy with taxes are good things, but the tax itself is a bad thing, right? You induce sort of distortions in behavior, deadweight loss from taxes is in the economic terms, that are just bad. What you buy with the tax is good, right? So similarly with diseases and epidemiology, the self-protection is like a tax imposed on us by the disease. So there's this notion in economic epidemiology of excess burden, right? So if you have a disease on the x-axis, you compare diseases, a disease with very low mortality rate, say, or disease severity on the left, this theta L number, versus a disease that's really high mortality rate. Think Ebola on the right, and I don't know, maybe a cold or something on the left. Well, the epidemiologic cost of the disease could be like sick days. It could be, actual deaths. It could be all kinds of things. There's this strange phenomenon that the epidemiologic burden of disease actually has this inverted U shape. Well, why is that? For the diseases that are most severe, people undertake the most actions to protect themselves from it. Vaccines, of course, if they're available. We've seen this with COVID, like the compliance with lockdowns. So the epidemiologic burden rises and falls with disease severity. Same time, that doesn't mean a disease on the right is not imposing costs. Smallpox, for instance, still imposes costs, even though it's gone, in the form of vaccine that we keep just in case of bioterrorism events. Right, the excess burden of disease counts both the costs of self-protection, that's what the excess burden is, plus the epidemiologic cost from the disease. The total cost of the disease is the sum of those two things: excess burden plus epidemiologic costs. So if you do a little analysis of the yearly cost of smallpox for industrialized countries and small developing countries in 1967, right? Was it worth it? Well, industrialized countries, there was no smallpox, not very much. The epidemiologic costs were zero since no one was actually getting smallpox, everyone was vaccinated. The excess burden was the vaccination costs. The campaign costs in those countries was the portion was $7.5 million per year. It wasn't actually, it's not like a lot of money, but it was $1967. In developing countries, there was a huge epidemiologic burden because a lot of people got and died from smallpox. The cost of care for smallpox also was high. The excess burden was lower because there was not as much vaccination going on. And the campaign costs per year were higher, borne by the developing countries. If you do a net present value calculation and ask, what was it worth it? The answer is absolutely yes. The net present value of return from that investment in smallpox eradication yielded 36% a year. I mean, that's like you put your money in the bank and you get 36% out with certainty. That was an enormously good investment for smallpox eradication, right? So the net present value compares the cost of the campaign versus the benefits from reductions in both the excess burden and epidemiologic costs, and it turns out to be hugely beneficial. Okay, so now let's turn our attention to COVID. Is COVID a good candidate for disease eradication? Okay, so just remember what the criteria are. First, COVID is worldwide and widespread, right? So this is from the latest Hopkins map. This map is familiar. Even Australia has cases. New Zealand, of course, doesn't. But everywhere else, Europe and the Americas are just dotted with cases. Only a small fraction of COVID-19 infections are actually identified as cases. So I worked on a couple of seroprevalence studies in the early days of the epidemic in Santa Clara County, Los Angeles County, where we found that there were 40 to 50 times more cases or more infections than cases. That's because COVID-19 infection has a range of clinical outcomes, ranging from completely asymptomatic and hence unlikely to voluntarily come to the attention of public health authorities, ranging to this horrible viral pneumonia and then everywhere in between. Even today, in countries that have an enormous amount of testing like the United States, the fraction of cases identified is something on the order of maybe 20%, 1 in 4, 1 in 5, 25%. Okay, so we don't have a technology to identify all infections. There was an attempt made in Slovakia, I think, to simultaneously test within the course of 2 weeks, I think, a very large fraction of its population, and yet cases still continue to rise because they didn't capture all the infections. It's not technically feasible. We don't, and I don't mean technically in terms of the PCR test. I mean in terms of like technically in terms of simultaneously testing an entire population all at once. They're animal reservoirs. I picked these pictures because I wanted to tug at your heartstrings with this picture of this cute cat and these dogs. But the bad news is cats have been found with COVID-19. Dogs have been found with COVID-19. Bats, of course, and minks as well, as you can see from the famous Danish experience of culling minks that have been found with some variant of COVID-19. There are animal reservoirs, and it clearly spreads between humans and animals. We don't fully know exactly the extent of it, but it's possible. This is not like smallpox where there's only human to human spread. This probably doesn't even need to be said, but I kind of feel like it needs to be said. If you want zero COVID, it's not enough to point at New Zealand and point and say success there. If you want zero COVID, you have to have zero COVID everywhere, or else you continue to pay the excess burden of disease everywhere for all time, right? Until it's gone. A single nation with zero COVID is always at risk from reinfection from the outside. Like that's the key thing. Zero COVID is a utopian. Well, I mean, for some people, a utopian dream. To me, a utopian nightmare. I haven't made the nightmare case yet, but I'm going to. There's a long timeline to vaccinate the world. This is from a CNN story that says it'll take until 2024 to get enough vaccines that we can vaccinate the world. That's probably a little bit pessimistic. I suspect we could do it faster if we put our mind to it. The issue is not technically getting enough vaccines, but actually getting everyone in the world to vaccinate in time, but before the immunity induced by vaccination wanes. Again, this is just like trying to test everyone in the world at once. It's just not technically feasible. It's a very long time, I'd say, to vaccinate the world, even if you can produce enough vaccines quickly. The development of variant strains also poses a challenge for zero COVID. The development of variant strains, it threatens to increase disease infectivity. In fact, I think that's the argument for the B117 variant and the South African strain. They threaten to make existing vaccines less effective at preventing disease spread and disease-related mortality. Actually, my reading is that so far that's not true. That the variants thus far have not actually made the vaccines actually cover the variants. In any case, since with this mRNA platform, in principle, you could alter it. But if it does happen, if it does actually happen that you get a variant that reduces that increases in infectivity, evades the vaccine, and is more deadly, well, it'll greatly increase the time until zero, to the extent, and I don't think it's possible now, but it would make it utterly impossible. And it'll also greatly increase uncertainty around the policy. Every time there's a new variant, there'll be a new lockdown. Okay, and others have mentioned this. I know Professor Gupta has made this, and this is where I learned this from her. So I'm just about, but I like to steal ideas from people I respect. So I'll do that. There's an irony in vaccine development, and that countries that have a very low COVID infection load could not, in principle, have played any role whatsoever in the development of the vaccine. Because in order to test the vaccine, you actually have to have some risk of getting infected. Second, countries that are currently near zero COVID can play no role whatsoever in revising the vaccines to deal with any new variants that escape existing vaccines. In a sense, a country that has zero COVID, like New Zealand by itself, is engaging in a beggar thy neighbor epidemiologic policy. It's relying on others to be infected so that it can get protected. Now it runs the other direction, right? Of course, other countries have not been as successful in New Zealand in controlling the spread of the disease. So, in a sense, it's not a question of finger pointing or blame. The point is, we're all in this together, right? There's no way around that fact. You can't just be an island and isolate yourself from the rest of the world unless you really have that as your philosophy for the rest of all time. So, is zero COVID worth it? I've now wanted to make the case for it is a nightmare, and I'm going to make that case just by pointing out a few lockdown harms, because that's the tool that the zero COVID proponents have in mind. These lockdowns that New Zealand has sort of escaped, but well, except for certain periods that have led to huge damage to its economy. But the rest of the world, especially Europe and the Americas, is still facing. And the case I'm going to make is based on the economic harm caused by these continuing lockdowns. The economic harm has its effect, of course, on the developed world, but it also has an enormous effect on the developing world that I think offsets almost any benefit you can imagine from zero COVID. So first, in April of 2020, the World Food Program estimated that there would be 130 million people at risk of starvation worldwide as a consequence of the economic harm of the lockdowns. That is unfortunately, something like that has unfortunately come true. There's a recent science paper by this group at Berkeley that's documented this kind of massive food insecurity worldwide. We're going to see and are seeing already an enormous effect on the world's poor. Every poor person on the face of the earth has been harmed by these lockdowns. Missed vaccinations, right? So the World Health Organization estimates that because of the lockdowns, the programs that that have been working to vaccinate the world's poor, the poor countries in the world have stopped. right? So at least 80 million children at risk of diseases like diphtheria, measles, polio, as COVID-19 disrupts routine vaccination efforts. The lockdowns will, if instituted, will continue to do this, right? The missed healthcare services in the United States, missed cancer diagnoses, cancer screening. The lockdowns have had, because we focused only on COVID-19, we've ignored an enormous number of other public health threats, including cancer, hemoglobin, diabetes screening, heart disease. The major killers in developed countries have been harmed by these lockdowns. Mental health, the mental health consequences of lockdowns are we're just beginning to sort of describe them, but they're just catastrophic. This statistic, in June of 2020, in the United States, 1 in 4 young adults 18 to 24 seriously considered suicide. One in 4, right? So that will continue, and it'll continue indefinitely as long as the lockdowns last in the bid to get zero COVID. Lastly, I promise, is the last slide on lockdown harms. I could go on actually for hours and hours on this, but I don't want to. I just want to give you some flavor of it. The lockdown harms, the lockdown benefits are incredibly unequally distributed. In Los Angeles County, where my mom lives, for instance, the LA County Public Health put out a study, a set of statistics looking at the mortality rate from COVID-19 in richer parts of versus poorer parts of Los Angeles County. So less than 10% poverty, we're talking about Beverly Hills, Santa Monica, where I once lived, 93 deaths per 100,000. In the poorer parts of Los Angeles County, 325 deaths per 100,000. The lockdowns protect the rich. The lockdowns will protect the people, the laptop class, the people who can stay at home and actually protect themselves and get food delivered to them. And it puts at risk everybody else. The lockdowns are not actually a universal tool that will protect everyone. They're a focused protection of the rich. It's in a sense, it's a form of trickle-down epidemiology. I'm going to talk. I'm going to say this just because I believe it strongly, although I think to a large extent we've sort of forgotten about it. Lockdowns are not consistent with democracy. They're not consistent with human rights. The lockdowns involve violations of the right to assembly, which means which includes assembly with having dinner with my extended family. Lockdowns have involved violations of free speech rights. We've seen censorship in science on a level not seen since the Soviet Union suppressed just free discussion of genetics. But you have a violation of children's right to education throughout the United States and in many other countries. A violation of property rights as businesses get arbitrarily closed. And a violation of due process as we involuntarily confine huge populations of people, as both New Zealand and Australia continue to occasionally have happen. In New Zealand itself, you have this national isolation with the decimation of the tourism industry. I think it's 10% of GDP of something on the order of 10% of GDP of New Zealand is basically gone overnight. With a big decrease, a big hit to the growth rate. This was from October, the IMF estimate. The IMF 2020 estimate was 6%. I think it's gotten a little bit better since then. They're projecting a bounce back, but it depends on if there's another lockdown. If you have a zero COVID policy and you have a case that pops up, you could see the growth rate change overnight downward, right? You have this great uncertainty that kills economies with intermittent lockdown, right? So this was from August of last year. You all remember a couple of cases was found that resulted in closure again of New Zealand. That could happen over and over again, right? You just don't know because the cases could slip in. Are there benefits? Well, that depends on how likely you think this has happened. If you think of the world as zero COVID forever, if we just bear down hard enough, you say, okay, yeah, there's going to be benefits that we can imagine. The problem is it's not technically feasible. There is no chance that a lockdown-focused policy will lead to zero COVID. Only the laptop class can actually afford to truly isolate, and that's only because the essential class, the essential worker class, serves their needs. We have this bifurcated world. That the lockdowns assume that we have this uniform ability lockdown. COVID meets none of the technical criteria for disease that can be eradicated. And the messaging that zero COVID proponents have that the world can have the openness of New Zealand ignores epidemiological reality. It's a form of propaganda. I heard this in the previous talk, which I thought was really right. There are other diseases that deserve our attention, that are afflicting the poor, that are afflicting people worldwide, that actually could be eradicated if we put our mind to it. Guinea worm, drocunculus, yaws. I just picked three that I think. Drocunculus is this worm that I mean, you can see this terrible picture of it. It's easily identifiable. We've made an enormous amount of progress. It's also easily treatable once it's identified. There's political commitments from governments where the disease is limited geographic. It has all of the characteristics of a disease that can be eradicated if we just put our mind to it. Yaws is another disease where in 2012 there was a major breakthrough in yaws. It turns out that you can give a dose of an oral antibiotic and it cures it. This deadly disease that's harmed, the skin disease has harmed like millions and millions of people, is on the brink of eradication. But we have potentially commitments from governments to address this. The point I want to make with these is COVID-19, a zero COVID policy would take our attention away from these diseases. It's not actually possible to, as you can see from the collapse of the vaccination programs worldwide, to focus on disease eradications that actually do inflict millions and millions of lives, while at the same time focusing on zero COVID. It is not. You may say that it's possible. It's not actually possible. What should you do instead? Well, I think focus protection and the Great Barrington Declaration is a smarter policy. Now that we have the vaccines, we can use it to protect vulnerable people. Who are the vulnerable people? The vulnerable people are older people, people with chronic diseases. Use the vaccines as rapidly as we can to protect those populations. Even apart from the vaccines, until we get the vaccines widely distributed enough to protect them, use the tools of isolating nursing homes, of all the sort of tools that the Great Barrington Declaration argued for to protect vulnerable populations. And now with the vaccines, we have a perfect tool to do so. In the meantime, lift the lockdowns to the extent possible so that kids can go back to school. We can have something resembling normal life, because the lockdown harms are so devastating for the non-vulnerable. So I'm gonna stop there, and hopefully I've made my case so you can see. I think the key thing is a zero COVID policy sounds good, but there are better policies available. That there are better ways to address the needs of the world than a zero COVID policy. It's not technically feasible.
Thanks, Jay. Wonderful. Lots of detail and well argued. I wonder if we could, if you could just discuss for a moment meaning, or in terms of the people's phrases around zero COVID or elimination or eradication. And just, I'm just going to mention that in New Zealand, the person who is one of the professors, Michael Baker, who's been accredited with our elimination goal, he's thinking about it as an eradication. New Zealand has officially said it's got an elimination goal, but they've begun referring to it as an elimination strategy, which is time bound. So you do an elimination strategy until there's this point where you don't. So I'm just wondering if you could discuss, are all those things meaning the same, or are they different? What are people thinking?
Well, I think, I mean, it sounds to me like there's an acknowledgement that eradication can't, first of all, it can't be done by one country, right? It has to be a worldwide effort, or else New Zealand will always face the same risk just from outside. You'll have to keep your borders closed forever. The strategy, well, I mean, it's very different in some place like New Zealand, where their strategy just means, well, let's wait until we find a case, lock down the area that has the case, and then we'll go on with our lives most of the rest of the time, except for the fact that you're not allowed to fly out and in without being quarantined for 14 days, or maybe those kinds of restrictions. In much of the rest of the world, especially Europe and the Americas, it means extended lockdowns and draconian Chinese-style lockdowns for a very, very, very long time. And even then, I don't think it's feasible. I think that so the strategy is not. If you think about it as a strategy in a single country, you've already made a mistake. It has to be a strategy that's worldwide.
Right. I just want to read out to you, if you don't mind. This is Michael Baker, who has been arguing for elimination internationally as well. He says it's been done for smallpox. He wrote this in The Guardian, I think. It's very close to being done for polio. In many ways, it will come down to the basic biology of infection, the effectiveness of the vaccine, and cost effectiveness, which are points you've made. But we might just conclude that it's actually more efficient to continue with a zero COVID approach. He references the original SARS virus, which had been eliminated through public health measures. He says one scenario could be regional elimination or even global eradication, as we saw with SARS. So New Zealand is definitely, or New Zealanders have been definitely positioned for thinking that elimination or even eradication is possible, that we could lead the world.
Yeah, I think it's incredibly naive, right? So first of all, there are animal vectors, right? So just even if we could successfully vaccinate the world, which I don't think is actually technically feasible, because there's going to be countries and places and people that will resist it. You would still have this potential for reinfection through animal vectors, right? So I don't think it's technically possible. Even beyond the technical possibility, in order to get there, we need to drive cases down to a sufficiently small number where it meets the standard of a small number of countries isolated geographically that look like smallpox. The smallpox example cuts against the possibility of COVID-19 eradication, not in favor of it. Same thing with the rinderpest eradication. I mean, those are successful campaigns that worked because the vaccine had cut the number of cases to a very small number. That's not true in this case. And in fact, what the COVID-19 proponents are arguing for is extended lockdowns, which haven't worked to reduce the spread of the disease in most of Europe and the Americas. Any evaluation of the costs and benefits needs to account for those costs of the lockdown. And ironically, among the costs of those lockdowns is the spread of polio in Pakistan and other places you're right, we had actually made a lot of progress toward the elimination of polio. The lockdowns shut down that progress. We're starting to see polio cases rise up again. There's trade-offs here that are implicit. If you just think monomaniacally about COVID-19, you're going to make the mistake of ignoring all of these other health conditions that deserve our attention, and it could make things worse. It's a complicated question. I think that's a greatly misleading argument that you read from that Guardian piece.
Right. Smallpox does sound like they were doing, if it was contact tracing, testing, finding the disease, perhaps contact tracing, isolation, that seemed to rest around that. And I think a lot of people who think that elimination is possible are very focused on the idea that this contact tracing system can work, that we can identify it, stamp it out. And I think smallpox perhaps shows that's possible. What would you say?
I mean, I think let's think about contact tracing. I think you're right. In the context of smallpox, it did work, right? It was a very, very enormous effort focused on very few cases, right, with an easily identifiable disease where you get these pustules that pop out, right? So now in the case of COVID-19, you have some complications that make it, I think, almost impossible for contact tracing to work when you have it widespread. Let me just give you a few sort of very, very simple economic kinds of ideas. So first some facts. One is that the majority of people contacted by contact tracers will not cooperate with them. They give them zero people that, no, I don't have any people. Of course, no, I don't have any family members. I've never been out. I've been sitting at home. I don't understand how I got it, right? I mean, they won't even return the calls. In LA County, I think it's like 60% of people won't return the call of the contact tracers.
Wow.
Well, why is that? Well, it's very simple. Do you really want to rat on your friends and give them 14 days when you don't know that they have the disease? I mean, it's human nature that you want to protect your friends from this. We created this like shame around this, which is an enormous public health messaging problem around getting COVID. And of course, people won't cooperate, right? So a second, and this is just such an obvious technical point that I can't believe that epidemiologists make this mistake. When the disease is very, very widespread and often asymptomatic, contact tracing cannot work to eradicate the disease. Just simply cannot. There's too many people with the disease per contact tracer. It takes too long. I think in New York City, it's something like 9 days between the time the case is assigned to a contact tracer and the first contact is actually made. By that time, you may as well just randomly go, test the population rather than the people that were contacted, because they're just as likely to have the disease as anyone else. It just doesn't make any sense. Technically speaking, I think contact tracing cannot work as a disease eradication tool in this case. It can be useful in certain cases when the number of cases, I think in New Zealand, contact tracing could be quite useful actually, because your number of cases is small.
Yeah.
But elsewhere, I don't know. I mean, you still have, of course, this problem of incentives of reporting. The other thing I think, this is not sort of well studied, but really should be, when you link the positive identification of a case to contact tracing and this sort of extensive sort of investigation, you actually decrease the incentives for people to get tested in the first place. Especially for disease where it's like 99.9, people under 70, the survival rate is 99.95%, according to seroprevalence studies worldwide. I'd rather face the 0.05% risk of death, especially since there's not, the treatments aren't all that great. I mean, there's a few, someone mentioned in the Q&A, vitamin D, which I think is actually quite effective for some things, but there's still no good treatment really. So what's the advantage to me to being identified? I just won't get tested. The cost of being tested to me in the form of I'm going to have a contact tracer reach out to me is just too high. So I think this policy is just economically naive.
Yeah, we have our own challenges in New Zealand, even though it's achievable as a smaller population. We had what looked like an outbreak in the top part of the country, and the media and government made a big deal about 1% of the population that got itself tested, of that population, got itself tested in the first 24 hours. But it was 99% of the population didn't. So, which goes to your point, really, that resistance is there. You mentioned asymptomatic transmission or otherwise. Yeah, what's the latest data on that? Because it's been bouncing around all over the place about whether asymptomatic, the percentage of people who have got the virus and are asymptomatic, and the potential for those people to pass the disease on.
So I think the first is probably a large fraction of the cases are asymptomatic. I mean, I've seen numbers somewhere ranging between 20 to 40 to 50% of the cases are asymptomatic. I don't know it probably varies from place to place. I don't know the exact number. I think it varies really closely with what the fraction of the old that are in your population. If you have larger fractions of young in your population, you'll have larger asymptomatics. Larger fraction of asymptomatics, because kids, for instance, are more likely to asymptomatic disease than older people.
Right.
As far as like the probability of transmission, there was this fascinating study, I think published in December in the Journal of the American Medical Association, that looked at, it was a meta-analysis of 54 other studies or 45 other studies of asymptomatic, of spread of the disease within households. And the major finding was that if you have somebody who's positive and asymptomatic, they pass on the disease to fellow household members, that is, people you live with and love and hug and stuff, that 0.7% of the time, 0.7%. Whereas if they're symptomatic, they pass on the disease 20% of the time to fellow household members. I think asymptomatic spread is incredibly inefficient relative to symptomatic spread, which is actually incredibly good news. Right. But as far as zero COVID, the fact that somewhere between 20 and 40, maybe higher percent of the population has asymptomatic disease and can still pass the disease on makes it technically almost impossible to achieve the end. I mean, in a population where the disease is widespread.
Two more questions. We've got a couple more minutes. In New Zealand, when there's a debate about, should we carry on with our current policy, or should we adopt something like the focus protection? It always comes down to, in terms of the government and the people who support elimination lockdowns, that their only argument is, where else would you want to live? I mean, from here in New Zealand, where there's people outside today, everyone's walking around. There's events tonight at the stadium, concerts and the rest of it. It does feel very good. Is there going to be, do you think there's potentially a downside at any time for our rather unusual circumstances?
I think the main downside for New Zealand is the isolation from the rest of the world. I mean, at some point that's going to eat on you. You'll want some visitors from outside. I personally would love to come visit New Zealand, but 14 days is too long. I think so. I think there's some element of that. It's actually interesting. Like my friend sent me these videos, right? So I get videos from New Zealand of people walking around, being normal, and I get videos from like Sweden and Florida. And they're like, I live in California. All of them look like videos from a foreign country. Every single last one of them. It's like a, I now think of it as the before times and the after times, right? Where they're all videos from the before times, as far as I'm concerned, where kids can go to school and play with their friends, and I can hug you can hug your grandma. I mean, all those things are possible, but it's Sweden and Florida which have followed something like, not both imperfectly, something like a focus protection policy, and New Zealand, which has followed effectively an effective zero COVID policy. My argument isn't that it would have been great if the world could have had New Zealand, could have been like New Zealand. I mean, in a sense, New Zealand picked up the few cases it had early enough where that policy actually could have been effective. And the rest of the world was not nearly so lucky. Right. So in April 4th, we found 50,000 infections based on antibody evidence in Santa Clara County, California. It was already too late by April 4th. It was already too late by March, and it was already too late by February in the United States. There's too much international contact back and forth to follow an effective zero COVID policy in the United States.
Right. One last question for you. I said I was going to ask it about the Great Barrington Declaration. Do you think it achieved what you'd intended? And how does it feel now? Because it's some months gone. Is it sort of fading into the distance?
Well, I think the principle is the same, and it's still quite important, right? So how should we deal with the vaccine, for instance? Well, you should use focus protection, right? You should use it to protect the vulnerable. That's the basic idea of the Great Barrington Declaration. That's still true, right? I mean, and in fact, it's more relevant because of the vaccine, because we can now answer the argument very, very effectively about, can you actually do focus protection? Did it achieve what I wanted? I'd hoped that the public health community worldwide would engage with us in thinking of better ways to do focus protection of the vulnerable. And instead, they had this like sort of almost immune response to the idea that could be any COVID at all. I mean, I think this zero COVID idea has been poisonous to discussion among public health folks. We should have, from the very beginning of the epidemic, been thinking about how to protect the vulnerable. And the only tool we've had that we really have sort of has reached mainstream adoption is lockdown, which has failed. So I think that's the other part that I think has been really effective about the Great Barrington Declaration. We brought focus to the harms of the lockdown. I don't think it's deniable that it's harmful, and to the extent that we managed to bring people to understand that a little bit better, I'm pretty pleased by that. It's been a tumultuous few months, I have to say, but yeah.
I think we are all grateful that you did do it, everybody on here and others, but in particular, what it did was give scale to arguments that we were all holding separately and individually within our countries. That in itself was a very important thing, I think, for the movement, as it were, for want of a better term.
I mean, I think the issue was just, I think a lot of people had these ideas. The shocking thing to me was the silencing of people who had these ideas.
Yeah.
Instead of having an open scientific debate, it's dangerous to say out loud what you're thinking. Right. So the main thing, and I should have mentioned this in answer to your other question, I think it gave people an opening to say, look, it's safe to actually say the ideas that say what you're seeing. And it's broadened the scientific debate, I think, around this. And that's just healthy.
Yeah. Jay, thank you very much for being on and taking the time for that presentation. Really honored to have you with us. Thank you.
Thank you.